Welcome to this comprehensive continuing education course on HIV and AIDS, designed specifically for Florida healthcare professionals. I'm glad you're here, because the knowledge you'll gain over the course of this lecture is not only essential for maintaining your professional licensure, but more importantly, it will directly impact the quality of care you provide to patients who are at risk for or living with HIV. Human immunodeficiency virus and acquired immunodeficiency syndrome remain significant public health challenges more than 4 decades after the first cases were identified. Despite remarkable advances in prevention, testing, and treatment, HIV continues to affect millions of people worldwide, with substantial disparities in incidence, prevalence, and outcomes across populations and geographic regions. And here's something particularly important for those of us practicing in Florida. Our state bears a disproportionate burden of the HIV epidemic in the United States, consistently ranking among states with the highest rates of new diagnoses and persons living with HIV. As healthcare professionals, you play a critical role in addressing the HIV epidemic through prevention counseling, testing and diagnosis, linkage to care, treatment management, and ongoing support for persons living with HIV. The quality of care you provide directly impacts individual health outcomes and broader public health goals, including the federal Ending the HIV Epidemic initiative, which aims to reduce new HIV infections by 75% by 2025 and 90% by 2030. This course provides comprehensive, evidence-based education on HIV and AIDS while emphasizing Florida-specific epidemiology, resources, and legal requirements. By the time we're finished, you will have enhanced your knowledge and clinical competencies to provide high-quality, compassionate care to persons at risk for or living with HIV. Before we dive into the clinical content, let me briefly address why you're likely taking this course in the first place. Florida Statute 456.033 establishes mandatory HIV and AIDS education requirements for healthcare professionals as a condition of licensure renewal. The statute recognizes that healthcare professionals must possess current knowledge of HIV and AIDS to provide safe, effective care and to protect public health. The required educational content encompasses the modes of transmission, infection control procedures, clinical management, prevention strategies, and the psychosocial aspects of HIV and AIDS. This course fulfills those statutory requirements by providing comprehensive coverage of all mandated content areas, reflecting current clinical guidelines and evidence-based practices. By the end of this course, you will be able to describe the current epidemiology of HIV and AIDS at global, national, and Florida-specific levels, including identification of high-prevalence regions, demographic disparities, and populations disproportionately affected by HIV infection. You'll be able to explain the pathophysiology of HIV infection, including viral structure, the replication cycle, mechanisms of CD4-positive T-cell depletion, disease progression from initial infection to AIDS, and recognition of opportunistic infections and AIDS-defining conditions. You'll learn to differentiate among HIV prevention strategies, including pre-exposure prophylaxis known as PrEP, post-exposure prophylaxis known as PEP, treatment as prevention, and the concept of undetectable equals untransmittable, behavioral interventions, and harm reduction approaches. You'll be able to identify appropriate clinical applications for each of these based on patient risk factors. Additionally, you'll learn to compare HIV testing modalities, interpret testing algorithms and results including window periods and confirmatory testing, and recognize the clinical presentation of acute HIV infection. You'll be able to summarize current antiretroviral therapy principles, including first-line integrase inhibitor-based regimens, rapid start protocols, monitoring parameters, drug resistance considerations, management of special populations, and adherence strategies. You'll understand the components of the HIV Care continuum, describe barriers to care engagement and retention, and explain evidence-based strategies and Florida-specific resources that support viral suppression. And finally, you'll recognize the legal and ethical responsibilities of Florida healthcare providers regarding HIV and AIDS, including Florida statutes on testing and consent, confidentiality requirements, partner notification laws, and anti-discrimination protections. Now let's begin our journey through this material by examining the epidemiology and public health impact of HIV. According to the Joint United Nations Program on HIV/AIDS 2024 Global AIDS Update, approximately 40.8 million people were living with HIV globally at the end of 2024, with 1.3 million new infections occurring during the year. While new infections have declined significantly from peak levels of over 3 million annually in the late 1990s, progress has slowed in recent years, raising concerns about meeting global elimination targets. The World Health Organization reports substantial but uneven global progress toward what are called the 95-95-95 targets. These targets mean that 95% of people living with HIV should know their status, 95% of those diagnosed should be receiving antiretroviral therapy, and 95% of those on treatment should achieve viral suppression. Current estimates show 87% know their status, 77% are receiving antiretroviral therapy, and 73% have achieved viral suppression. These figures represent remarkable progress but reveal persistent gaps requiring intensified efforts. Sub-Saharan Africa continues to bear the greatest burden of the global epidemic, accounting for approximately 2/3 of all people living with HIV. However, the epidemic affects every region of the world, with increasing concern about rising infections in Eastern Europe, Central Asia, the Middle East, and North Africa. Gender disparities persist globally, with women and girls accounting for approximately 53% of all people living with HIV. Turning our attention to the United States, according to the CDC 2025 HIV Surveillance Update, an estimated 1.2 million people were living with HIV in the United States at the end of 2023, with approximately 39,201 new diagnoses during the year. This represents a continued decline from historical peaks, reflecting the impact of expanded testing, treatment, and prevention efforts, though the pace of decline has slowed in recent years. The geographic distribution of the United States epidemic reveals marked disparities. The southern region accounts for approximately 51% of all new HIV diagnoses, despite representing only 38% of the national population. This concentration reflects the intersection of multiple factors, including poverty, limited healthcare access, stigma, and policy environments that may impede prevention efforts. Within the South, Florida, Georgia, Texas, and Louisiana consistently report the highest numbers of new diagnoses. The United States epidemic is characterized by significant demographic disparities. Men who have sex with men continue to be the population most affected by HIV, accounting for approximately 67% of new diagnoses. Racial and ethnic minorities are disproportionately affected. Black and African Americans represent approximately 38% of new HIV diagnoses, despite comprising only 12% of the United States population, while Hispanic and Latino individuals account for approximately 27% of diagnoses. These disparities reflect social determinants of health, including structural racism, economic inequality, and differential access to prevention and treatment services. Now let's focus specifically on Florida, because understanding our state's epidemic is essential for providing effective care to our patients. Florida consistently ranks among the states most affected by HIV in the United States, making comprehensive HIV and AIDS education particularly important for Florida healthcare professionals. The Florida Department of Health Bureau of Communicable Diseases maintains detailed HIV and AIDS surveillance data that reveals the scope and characteristics of the state's epidemic. Florida reported over 4,500 new HIV diagnoses in 2023, placing it among the top 3 states for new diagnoses nationally. The state also has one of the highest rates of HIV-related mortality in the nation, reflecting challenges in linkage to care, retention in treatment, and viral suppression. The HIV Care continuum in Florida shows that while approximately 85% of persons living with HIV have been diagnosed, gaps exist at each subsequent step, with only approximately 66% achieving viral suppression. This is below the national average and substantially below the 95% target. Geographic distribution within Florida is highly concentrated. Miami-Dade County consistently reports the highest number of new diagnoses in persons living with HIV, followed by Broward, Palm Beach, Orange, and Hillsborough counties. These 5 counties account for the majority of Florida's HIV burden, though the epidemic affects all regions of the state. Rural areas face particular challenges, including limited access to specialized HIV care, greater stigma, and transportation barriers. Demographic patterns in Florida's epidemic mirror national trends while reflecting the state's unique population characteristics. Men who have sex with men represent the largest transmission category, followed by heterosexual transmission and injection drug use. Racial and ethnic disparities are pronounced. Black and African American Floridians represent approximately 42% of new HIV diagnoses, despite comprising only 16% of the state population. Infection rates among Black Floridians are approximately 8 times higher than among white Floridians, reflecting structural inequities rather than individual behaviors. Understanding and addressing demographic disparities is essential for effective HIV prevention and treatment efforts. Research provides comprehensive analysis demonstrating how social determinants of health, including poverty, housing instability, educational attainment, employment, and healthcare access, intersect with structural factors like racism and discrimination to produce differential HIV outcomes. Research documents disparities in PrEP access, with Black individuals less likely to be prescribed PrEP despite higher HIV incidence. Similar disparities exist in timely diagnosis, linkage to care, retention, and viral suppression. Addressing these disparities requires multi-level interventions targeting social determinants, healthcare system barriers, and individual-level factors. To summarize the epidemiological picture across geographic levels, globally, we have 40.8 million people living with HIV with 1.3 million new diagnoses in 2023, with key affected populations being sub-Saharan Africa, women and girls, and key populations. In the United States, we have 1.2 million people living with HIV, with approximately 39,201 new diagnoses, with men who have sex with men accounting for 67%, the South region accounting for 51%, and Black and African Americans accounting for 38%. In Florida specifically, we have approximately 140,000 people living with HIV, with roughly 4,500 new diagnoses, with key affected populations being men who have sex with men, Black and African Americans at 42%, and concentration in Miami-Dade, Broward, and Palm Beach counties. Now that we have a clear picture of the epidemiology, let's move on to understanding the virus itself, its pathophysiology, and the natural history of infection. Human immunodeficiency virus belongs to the family Retroviridae and the genus Lentivirus, characterized by long incubation periods and chronic infection. HIV-1 is responsible for the vast majority of infections worldwide and is classified into groups M, N, O, and P, with subtypes within group M. HIV-2 is primarily found in West Africa and is associated with slower disease progression, lower transmissibility, and intrinsic resistance to non-nucleoside reverse transcriptase inhibitors. The HIV variant is an enveloped particle approximately 120 nanometers in diameter. The outer lipid envelope is derived from the host cell membrane and contains the viral glycoproteins GP120 and GP41, which form trimeric spikes essential for viral entry. Beneath the envelope lies the matrix protein known as P17, and within this is the conical capsid, P24, containing 2 copies of the single-stranded RNA genome along with essential viral enzymes, reverse transcriptase, integrase, and protease. Understanding viral structure is clinically relevant because antiretroviral drugs target specific viral proteins, and mutations in viral genes can confer drug resistance. The HIV replication cycle consists of several distinct steps, each representing a potential target for antiretroviral therapy. The cycle begins with attachment and entry. The viral GP120 glycoprotein binds to the CD4 receptor on target cells, primarily CD4-positive T lymphocytes but also macrophages and dendritic cells. This binding induces conformational changes, allowing interaction with the co-receptor, either CCR5, which is used by R5 tropic viruses and is predominant in early infection, or CCR4, which is used by X4 tropic viruses and is associated with more advanced disease. Following co-receptor binding, GP41 mediates fusion of the viral and cellular membranes, releasing the viral capsid into the cytoplasm. Following entry, the viral capsid is transported toward the nucleus while undergoing uncoding. Reverse transcriptase converts the single-stranded viral RNA into double-stranded DNA called proviral DNA. This is a process that is highly error-prone due to lack of proofreading function. This error rate of approximately 1 mutation per genome per replication cycle generates enormous viral diversity, contributing to drug resistance and immune evasion. Viral integrase then catalyzes insertion of the proviral DNA into the host chromosome. This is a critical step that establishes persistent infection and necessitates lifelong treatment. Once integrated, the provirus may remain latent or undergo transcription depending on cellular activation status. In activated cells, host transcription factors drive viral gene expression. Viral proteins are produced and assemble at the plasma membrane. New virions bud from the cell surface, acquiring their lipid envelope in the process. Viral protease cleaves polyprotein precursors to generate mature infectious virions. Understanding immunopathogenesis is crucial for clinical practice. HIV preferentially infects and destroys CD4-positive T lymphocytes, the central orchestrators of adaptive immunity, through multiple mechanisms. Direct viral cytopathic effects result from viral budding, accumulation of unintegrated viral DNA, and disruption of cellular membranes. However, the majority of CD4-positive T-cell death occurs through indirect mechanisms, including bystander apoptosis of uninfected cells, pyroptosis, which is an inflammatory cell death triggered by incomplete viral products, and immune-mediated killing of infected cells by cytotoxic T lymphocytes. Beyond CD4-positive T-cell destruction, HIV infection induces chronic immune activation and inflammation that persist even with effective antiretroviral therapy. Factors contributing to immune activation include ongoing low-level viral replication, microbial translocation from the damaged gut mucosa, co-infections, and persistent viral protein expression from latent reservoirs. This chronic inflammation contributes to excess morbidity, including elevated risks of cardiovascular disease, neurocognitive impairment, and malignancies. The gut-associated lymphoid tissue is a critical site of HIV pathogenesis. Within days of infection, HIV massively depletes CD4-positive T cells in the gut mucosa, particularly Th17 cells that maintain epithelial barrier integrity. This damage allows translocation of microbial products into systemic circulation, driving immune activation. A major barrier to HIV cure is the establishment of latent viral reservoirs during early infection. HIV integrates into long-lived memory CD4-positive T cells, where the provirus remains transcriptionally silent, invisible to immune surveillance, and unaffected by antiretrovirals targeting active replication. Let me walk you through the natural history and disease staging. In the absence of treatment, HIV infection follows a characteristic clinical course, progressing through several stages. Acute HIV infection occurs within 2 to 4 weeks following exposure and is characterized by high-level viremia, with viral loads often exceeding 1 million copies per milliliter. An estimated 50 to 90% of newly infected individuals experience symptoms of acute retroviral syndrome: fever, lymphadenopathy, pharyngitis, rash, myalgias, arthralgias, headache, and mucosal ulcers. These symptoms often resemble infectious mononucleosis and typically resolve within 2 to 4 weeks. During acute infection, viral reservoirs are established, and the period represents both the highest risk period for transmission and a critical window for early diagnosis. Following resolution of acute infection, patients enter clinical latency with few or no symptoms despite ongoing viral replication and progressive CD4-positive T-cell depletion. Without treatment, CD4 counts decline at an average rate of 50 to 80 cells per microliter per year. As CD4 counts decline below 200 cells per microliter, patients become vulnerable to opportunistic infections and malignancies that define AIDS, including pneumocystis, Jirovecii pneumonia, Candida esophagitis, cryptococcal meningitis, Toxoplasma encephalitis, and CMV retinitis. 2 laboratory parameters are central to HIV care: CD4-positive T-cell count and plasma HIV viral load. CD4 count measures immune function and guides prophylaxis decisions, while viral load reflects viral replication and serves as the primary measure of treatment efficacy. The goal of antiretroviral therapy is achieving and maintaining undetectable viral load, which is less than 50 copies per milliliter. This prevents progression, enables immune reconstitution, and eliminates sexual transmission. Let me explain the clinical significance of CD4 counts at different levels. When the CD4 count is greater than 500 cells per microliter, this is classified as stage 1 with normal immune function and no prophylaxis is required. When the CD4 count is between 200 and 499 cells per microliter, this is stage 2 with moderate immunodeficiency, and close monitoring is needed. When the CD4 count falls below 200 cells per microliter, this is stage 3, which is AIDS, indicating severe immunodeficiency, and PCP prophylaxis with trimethoprim sulfamethoxazole is required. When the CD4 count falls below 50 cells per microliter, this indicates advanced AIDS with profound immunodeficiency, and MAC prophylaxis should be added. Here's an important clinical pearl about recognizing acute HIV infection. Acute retroviral syndrome presents 2 to 4 weeks post-exposure with fever, lymphadenopathy, pharyngitis, rash, and/or mucosal ulcers, often mimicking mononucleosis. Standard antibody tests may be negative during acute infection, so you should use 4th-generation antigen antibody tests or HIV RNA nucleic acid testing. Acute infection represents the highest transmission risk period, so immediate diagnosis enables early treatment and prevention counseling. Now let's transition to discussing HIV transmission and prevention, which is fundamental to your role as a healthcare professional. HIV is transmitted through specific routes involving exchange of body fluids containing the virus. Understanding these routes and their relative risks is essential for prevention counseling and post-exposure management. The primary modes of HIV transmission include sexual contact, parenteral exposure including injection drug use and occupational needle sticks, and perinatal or vertical transmission from mother to child. Sexual transmission accounts for the majority of HIV infections globally and in the United States. HIV can be transmitted through vaginal, anal, and rarely oral sexual contact with an infected partner. Risk varies substantially by type of exposure. Receptive anal intercourse carries the highest per-act risk, estimated at approximately 138 per 10,000 exposures, or 1.38%, reflecting the fragility of rectal mucosa and high density of target cells. Insert of anal intercourse carries an estimated risk of 11 per 10,000 exposures. Receptive vaginal intercourse risk is estimated at 8 per 10,000 exposures, while insert of vaginal intercourse risk is approximately 4 per 10,000 exposures. Parenteral transmission occurs through direct inoculation of infected blood. Sharing of injection equipment among persons who inject drugs is an efficient transmission mode, with estimated per-act risk of 63 per 10,000 exposures. Occupational needle stick injuries carry an estimated risk of 23 per 10,000 exposures, or 0.23%, for hollow bore needle injuries from an HIV-positive source. Perinatal transmission can occur during pregnancy, labor, delivery, or breastfeeding. Without intervention, transmission rates range from 15 to 45%. With appropriate interventions including antiretroviral therapy during pregnancy, optimal delivery management, infant prophylaxis, and avoidance of breastfeeding, perinatal transmission rates have declined to below 1%. It's important to emphasize to patients that HIV is not transmitted through casual contact, including touching, hugging, sharing dishes, mosquito bites, air, water, saliva, tears, or sweat. Healthcare professionals should address common misconceptions about transmission. Multiple factors modify transmission probability. The most important factor is the viral load of the HIV-positive partner. Higher viral loads increase transmission risk, while viral suppression dramatically reduces and effectively eliminates sexual transmission risk, which is the basis for undetectable equals untransmittable. Other factors include presence of sexually transmitted infections, which increase both susceptibility and infectiousness through inflammation, circumcision status, which reduces female-to-male transmission by 50 to 60%, and stage of infection, with highest risk during acute infection, when viral loads are extremely high. To summarize the risk levels by exposure type, receptive anal intercourse carries the highest risk at 138 per 10,000 exposures. Sharing injection equipment is high risk at 63 per 10,000. Needle stick injury from an HIV-positive source is moderate risk at 23 per 10,000. Receptive vaginal intercourse is moderate risk at 8 per 10,000. Insertive anal intercourse is moderate risk at 11 per 10,000. And insertive vaginal intercourse is low risk at 4 per 10,000. Now let's discuss one of the most significant advances in HIV prevention: pre-exposure prophylaxis, or PrEP. Pre-exposure prophylaxis involves antiretroviral use by HIV-negative individuals at substantial risk to prevent HIV acquisition. PrEP represents one of the most significant advances in HIV prevention and is a cornerstone of the Ending the HIV Epidemic initiative. When taken as prescribed, PrEP reduces HIV acquisition risk by approximately 99% from sex and at least 74% from injection drug use. The CDC Clinical Practice Guideline recommends PrEP for HIV-negative adults and adolescents weighing at least 35 kilograms who have had anal or vaginal sex in the past 6 months and have any of the following: an HIV-positive sexual partner, a recent bacterial sexually transmitted infection, inconsistent condom use, or commercial sex work. PrEP is also indicated for persons who inject drugs and share equipment. Healthcare providers should offer PrEP to all patients at substantial risk and engage in shared decision-making. Multiple PrEP options are available. Oral PrEP includes daily tenofovir disoproxyl fumarate emtricitabine, commonly abbreviated as TDF-FTC, daily tenofovir alafenamide emtricitabine, abbreviated as TAF-FTC, which is approved except for receptive vaginal sex risk, and on-demand 211 TDF-FTC for men who have sex with men. Long-acting injectable cabotegravir, abbreviated as CABLA, is administered every 2 months and was approved after the HPTN-083 trial demonstrated it was 66% more effective than daily oral TDF-FTC among men who have sex with men and transgender women. The HPTN-084 trial showed 89% greater effectiveness in cisgender women. Baseline evaluation for PrEP includes documented negative HIV test, kidney function assessment, hepatitis B serology, pregnancy test, and STI screening. Follow-up includes HIV testing at least every 3 months, kidney monitoring for TDF users, STI screening, and ongoing adherence support. Moving on to post-exposure prophylaxis, or PEP, this involves short-term antiretroviral treatment initiated after potential HIV exposure to prevent establishment of infection. PEP is used in both occupational settings, such as healthcare worker exposures, and non-occupational settings, such as sexual assault, condomless sex, and injection drug use. PEP should be initiated as soon as possible after exposure, ideally within 24 hours, and must begin within 72 hours to be effective. Earlier initiation is associated with greater effectiveness. Duration is 28 days. Preferred regimens include bictegravir, tenofovir, alafenamide, emtricitabine, abbreviated as BIC, TAF, FTC, or dolutegravir plus TAF, FTC. Follow-up includes HIV testing at 4 to 6 weeks and 12 weeks, monitoring for adverse effects, and counseling about PrEP if risk continues. One of the most transformative findings in HIV prevention is that effective antiretroviral treatment preventing viral replication essentially eliminates sexual transmission risk. This concept is known as undetectable equals untransmittable, or U equals U. This understanding fundamentally changed both public health and personal implications of HIV treatment. The scientific foundation for U equals U comes from landmark studies. HPTN-052, published in 2011, demonstrated that early antiretroviral therapy reduced sexual transmission by 96% among serodifferent couples, with no linked transmissions when the positive partner had sustained viral suppression. The partner studies followed both heterosexual and gay male serodifferent couples. After monitoring over 76,000 condomless sex acts, including anal sex, there were 0 linked HIV transmissions when the positive partner maintained undetectable viral load. U equals U has profound implications. For individuals living with HIV, knowing that effective treatment prevents transmission reduces stigma, anxiety, and fear of rejection. For public health, universal treatment becomes a powerful prevention strategy. For counseling, providers can accurately convey that persons maintaining undetectable viral load do not transmit HIV sexually. U equals U applies to sexual transmission when viral load has been suppressed below 200 copies per milliliter for at least 6 months. Let me also address harm reduction strategies, which encompass strategies that reduce negative consequences of behaviors without requiring complete abstinence. Syringe services programs are a cornerstone of HIV prevention among persons who inject drugs. These programs provide sterile syringes and injection equipment, safe disposal, HIV and HCV testing, linkage to substance use treatment, and naloxone distribution. Research demonstrates syringe services programs reduce HIV and HCV transmission by approximately 50% without increasing drug use. Additional harm reduction strategies include medication-assisted treatment for opioid use disorder, which reduces injection drug use and associated risk. Healthcare professionals can support harm reduction by providing non-judgmental care, offering HIV testing and PrEP to persons who inject drugs, prescribing medication-assisted treatment when appropriate, and referring to syringe services programs. Here's a clinical pearl on PrEP and U equals U counseling. A recent STI diagnosis is a strong PrEP indicator, so if you're treating gonorrhea, chlamydia, or syphilis, discuss PrEP with your patient. Injectable CABLA is ideal for patients with adherence challenges or pill-taking concerns. Remember the U equals U message. Persons living with HIV who maintain undetectable viral load below 200 copies per milliliter for at least 6 months do not transmit HIV sexually. Share the U equals U message to reduce stigma, improve adherence, and support quality of life. Now let's move on to HIV testing and diagnosis, which is your gateway to linking patients to life-saving care. Multiple types of HIV tests are available, each with distinct characteristics regarding what they detect, when they become positive after infection, and appropriate clinical applications. Healthcare professionals should understand these distinctions to select appropriate tests and interpret results correctly. Antibody tests detect HIV-1 and HIV-2 antibodies produced by the immune system in response to infection. These tests include rapid antibody tests with results in 20 to 30 minutes and laboratory-based immunoassays. Antibody tests are highly accurate once antibodies have developed but have a window period of approximately 23 to 90 days during which they may be negative despite active infection. Antigen-antibody combination tests, also called fourth-generation tests, detect both HIV P24 antigen, which is produced during acute infection before antibodies develop, and HIV-1 and HIV-2 antibodies. These tests have a shorter window period of approximately 18 to 45 days and are better able to detect acute HIV infection. Fourth-generation tests are the recommended initial test in current diagnostic algorithms. Nucleic acid tests, also called HIV RNA tests, directly detect HIV genetic material. Nucleic acid testing has the shortest window period of approximately 10 to 33 days and can detect infection during the eclipse period before antigen or antibodies are detectable. Nucleic acid testing is used for confirming acute HIV infection, diagnosing HIV in neonates, and monitoring viral load during treatment. Let me walk you through the recommended HIV testing algorithm. The CDC and APHL recommend a specific laboratory diagnostic algorithm for HIV testing. Step 1 involves initial testing with an FDA-approved fourth-generation HIV-1 and HIV-2 antigen-antibody combination immunoassay. If non-reactive, the result is reported as negative. If reactive, proceed to Step 2. Step 2 involves an HIV-1 and HIV-2 antibody differentiation immunoassay, which distinguishes HIV-1 from HIV-2 antibodies. If positive for HIV-1 and or HIV-2 antibodies, HIV infection is confirmed. If negative or indeterminate, proceed to Step 3. Step 3 involves an HIV-1 nucleic acid test. A positive nucleic acid test indicates acute HIV-1 infection, meaning there was a reactive initial test but antibodies have not yet developed. A negative nucleic acid test with negative differentiation assay suggests a false positive initial test. This algorithm has largely replaced Western blot confirmation, offering faster turnaround and better acute infection detection. To summarize the test types, rapid antibody tests detect HIV-1 and HIV-2 antibodies with a window period of 23 to 90 days and are best used for point-of-care screening. Fourth-generation antigen-antibody tests detect P24 antigen plus antibodies with a window period of 18 to 45 days and are the recommended initial lab test. HIV-1 and HIV-2 differentiation tests detect HIV-1 versus HIV-2 antibodies and are used for confirmatory Step 2 testing. Nucleic acid tests detect HIV RNA with the shortest window period of 10 to 33 days and are used for acute infection detection and monitoring. Recognizing acute HIV infection is critically important. Acute HIV infection represents the period immediately following HIV acquisition before a detectable antibody response develops. This period is clinically significant for several reasons. Symptoms of acute retroviral syndrome provide a diagnostic opportunity. Transmission risk is highest during this period of peak viremia. Early treatment initiation preserves immune function and may limit reservoir establishment, and standard antibody tests may be falsely negative. Acute retroviral syndrome occurs in an estimated 50 to 90% of newly infected individuals, typically 2 to 4 weeks after exposure. Common symptoms include fever, which is present in over 80% of symptomatic patients, lymphadenopathy, pharyngitis, rash that is typically maculopapular on the trunk and face, myalgias and arthralgias, headache, and mucocutaneous ulcers. The syndrome often resembles infectious mononucleosis and typically resolves within 2 to 4 weeks. Healthcare professionals should maintain high suspicion for acute HIV in patients presenting with compatible symptoms, particularly when risk factors are present. Testing should include a fourth-generation antigen antibody test, and if suspicion is high, HIV RNA nucleic acid testing. Let me review the screening recommendations. The United States Preventive Services Task Force assigns a Grade A recommendation to HIV screening for all adolescents and adults aged 15 to 65 years, for all pregnant persons, and for younger adolescents and older adults at increased risk. The CDC recommends routine opt-out testing in healthcare settings for ages 13 to 64. Higher-risk individuals should test at least annually, with testing every 3 to 6 months for men who have sex with men with multiple partners. Now let me discuss Florida-specific laws on HIV testing and consent. Florida's Omnibus AIDS Act, found in Section 381.004, establishes requirements for HIV testing, consent, and confidentiality. Informed consent is generally required before testing. Patients must receive information about the test and provide consent. Consent may be oral and documented in the medical record. Written consent is not required. Exceptions to the consent requirement include significant exposure incidents, court-ordered testing, prenatal care unless the patient declines, and documented medical necessity. Post-test counseling is required for reactive results, including explanation, disease information, and referral to care and support services. Positive results should be delivered in person. Negative results may be provided by telephone or mail. Regarding partner notification, Florida Statute Section 384.26 authorizes voluntary partner notification services. Healthcare providers must counsel newly diagnosed patients about partner notification importance and inform them about health department services. Disease intervention specialists can confidentially notify partners without revealing the index patient's identity, offering testing and prevention services. Here's another clinical pearl on testing in acute HIV infection. Standard antibody tests may be negative during the first 3 to 12 weeks of infection. Use fourth-generation antigen antibody tests, and if acute HIV is strongly suspected, order HIV RNA nucleic acid testing regardless of antibody status. Any patient with mononucleosis-like symptoms and recent HIV risk should be evaluated for acute HIV. Now let's transition to clinical management and antiretroviral therapy, which has truly transformed HIV from a progressive fatal disease to a manageable chronic condition. Antiretroviral therapy, or ART, has transformed HIV when taken as prescribed. ART suppresses viral replication, enables immune reconstitution, prevents HIV-related morbidity and mortality, and eliminates sexual transmission risk. These benefits form the foundation for current recommendations to offer ART to all persons diagnosed with HIV regardless of CD4 count. The primary goal of ART is achieving and maintaining viral suppression, defined as HIV RNA below the lower limit of detection, which is less than 50 copies per milliliter. Viral suppression prevents disease progression, enables CD4, positive T-cell recovery, reduces inflammation and associated comorbidity risk, and prevents sexual transmission. With effective treatment, life expectancy now approaches that of the general population, particularly when treatment is initiated early. Contemporary HIV treatment guidelines recommend initiating ART immediately upon diagnosis, including same-day start for patients who are ready and willing. This represents a significant shift from earlier approaches that staged treatment based on CD4 thresholds or completing extensive baseline evaluation before starting therapy. Evidence supporting rapid start includes improved linkage to care and retention, since patients who leave without starting may not return, faster viral suppression, prevention of ongoing transmission, and possible benefits for immune reconstitution and reservoir size when treatment begins an acute infection. Essential baseline tests before starting include HIV confirmatory testing if not completed, renal function including creatinine and estimated GFR, hepatitis B serology with HBV surface antigen at minimum, and pregnancy test for persons of childbearing potential. Results of other tests such as CD4, viral load, resistance testing, and STI screening can be awaited without delaying treatment. If resistance is later detected, the regimen can be modified. Let me walk you through the antiretroviral drug classes. Antiretroviral drugs are classified by mechanism of action, with each class targeting a different step in the HIV replication cycle. Nucleoside and nucleotide reverse transcriptase inhibitors, abbreviated NRTI, incorporate into growing viral DNA during reverse transcription, causing chain termination. Common NRTI include tenofovir in two forms, TDF or TAF, emtricitabine, abbreviated FTC, lamivudine, abbreviated 3TC, and abacavir, abbreviated ABC. NRTI form the backbone of most regimens. TDF carries renal and bone risks, while TAF has an improved safety profile. Integrase strand transfer inhibitors, abbreviated INSTI, block viral integrase required to insert HIV DNA into the host chromosome. INSTI are the preferred third drug in most first-line regimens due to potency, high resistance barrier, tolerability, and minimal drug interactions. Available INSTI include bictegravir, dolutegravir, and cabotegravir. Weight gain has emerged as a monitoring concern with INSTI-based regimens. Non-nucleoside reverse transcriptase inhibitors, abbreviated NNRTI, bind near the reverse transcriptase active site, impairing enzyme function. NNRTI, including efavirenz, rilpivirine, and doravirine, have largely been supplanted by INSTI in first-line regimens due to lower resistance barriers. Boosted protease inhibitors block viral protease. Darunavir and atazanavir are boosted with ritonavir or cobicistat. Protease inhibitors have high resistance barriers but more drug interactions. Now let me discuss the recommended initial regimens. The Department of Health and Human Services and International Antiviral Society guidelines recommend INSTI-based regimens for initial treatment. Recommended options include bictegravir, tenofovir, alafenamide, emtricitabine, abbreviated BIC, TAF, FTC, which is a single tablet once daily with high efficacy, high resistance barrier, and minimal interactions. Dolutegravir plus TAF, FTC, which is 2 pills daily, offers similar advantages. Dolutegravir lamivudine, abbreviated DTG 3TC, is an effective 2-drug option for patients without hepatitis B with viral load less than 500,000 copies per milliliter and no known resistance. Long-acting injectable cabotegravir plus rilpivirine, abbreviated CAB plus RPV, is administered monthly or every 2 months and is available for virally suppressed patients who prefer injectable therapy. The ATLAS and ATLAS 2M trials demonstrated non-inferior efficacy to daily oral regimens for maintaining suppression. Patient selection considerations include motivation for injections, ability to attend regular appointments, and absence of rilpivirine resistance. An oral lead-in period of 1 month of oral CAB plus RPV is recommended to assess tolerability before initiating injections. TAF is generally preferred over TDF for patients with or at risk for renal impairment or osteoporosis. Adherence to ART is essential for achieving and maintaining viral suppression. Modern INSTI-based regimens are more forgiving of occasional missed doses than older regimens, but consistent adherence remains important. Strategies to support adherence include simplifying regimens using single-tablet, once-daily regimens when possible, addressing barriers to adherence such as side effects, food requirements, cost, and complexity, using reminder systems such as pill boxes, alarms, and smartphone apps, integrating medication taking into daily routines, providing adherence counseling at each visit, screening for and addressing depression and substance use, and considering long-acting injectable therapy for patients who struggle with daily pills. If a dose is missed and it is within 12 hours of the usual time, the patient should take it. If more than 12 hours have passed, they should skip and resume the normal schedule. Persistent adherence challenges should prompt evaluation for barriers and consideration of regimen modification or long-acting injectable therapy. Viral load monitoring is the primary measure of treatment efficacy. After ART initiation, check viral load at 4 weeks, then every 4 to 8 weeks until suppressed, then every 3 to 6 months. The goal is sustained undetectable viral load. Confirmed viremia requires evaluation for adherence problems or drug resistance. For CD4 count, measure at baseline and 3 months. Once stable above 200 to 300 cells per microliter on suppressive therapy, it can be monitored less frequently, every 12 months. Additional monitoring includes renal function, lipid panel, and STI screening. The REPRIEVE trial demonstrated that pitavastatin reduced cardiovascular events by 35% in persons with HIV, supporting more aggressive lipid management. Resistance develops through the high viral mutation rate combined with incomplete suppression under drug selection pressure. Resistance testing is recommended at entry to care and upon virologic failure. Drug classes vary in genetic barrier to resistance. Boosted protease inhibitors and INSTI like dolutegravir and bictegravir have high barriers requiring multiple mutations for clinically significant resistance. NNRTI have low barriers where single mutations confer resistance. Let me briefly address special populations. For pregnancy, INSTI-based regimens, particularly dolutegravir, are now recommended including during the first trimester. With comprehensive interventions, perinatal transmission rates are well below 1%. For older adults, attention should be given to polypharmacy, drug interactions, and age-related comorbidities including cardiovascular, metabolic, and neurocognitive conditions. For hepatitis B co-infection, use regimens containing tenofovir plus emtricitabine or lamivudine, which are active against both viruses. Discontinuing these can precipitate severe HBV flare. Here's a clinical pearl on Rapid Start ART implementation. Offers same-day ART to all newly diagnosed patients who are ready to start. Essential baseline tests include HIV confirmation, creatinine and estimated GFR, HBV surface antigen, and pregnancy test. BIC, TAF, FTC, or DTG plus TAF, FTC are excellent rapid start options with once-daily dosing. Resistance results can follow, and if resistance is detected, adjust the regimen accordingly. Now let's discuss the HIV care continuum, which is essential for understanding gaps in care and how to address them. The HIV care continuum, also called the treatment cascade, depicts the stages of HIV care from initial diagnosis through viral suppression, diagnosis, then linkage to care, then retention in care, then ART prescription, and finally viral suppression. The continuum provides a framework for identifying gaps in care engagement and measuring progress toward national goals. In the United States, current estimates indicate approximately 87% of people living with HIV have been diagnosed, but significant attrition occurs at subsequent steps. Only about 66% achieve viral suppression, meaning one-third of people living with HIV are not optimally treated, with consequences for individual health including disease progression and morbidity, and public health consequences including ongoing transmission. Florida's care continuum mirrors national patterns with some variation. Approximately 85% of Floridians with HIV are diagnosed, but only about 66% achieve viral suppression, below both the national average and the 95% target. Disparities exist across populations, with younger people, Black and African Americans, and persons who inject drugs showing lower viral suppression rates. Understanding barriers to care engagement is essential for designing effective interventions and providing patient-centered care. Multiple barriers impede engagement at each stage of the care continuum. Structural barriers include poverty and lack of insurance, which limit access to care and medication, transportation difficulties, particularly in rural areas of Florida, unstable housing, which makes keeping appointments and storing medications challenging, food insecurity, immigration status concerns, incarceration and criminal justice involvement, and HIV-related stigma and discrimination that discourage testing and care seeking. These social determinants disproportionately affect communities already bearing the highest HIV burden. Healthcare system barriers include lack of available HIV specialty providers, particularly in rural Florida, long wait times for appointments, inconvenient clinic hours and locations, poor cultural competency among providers, lack of integration between HIV care and mental health, substance use or other needed services, administrative burden and complex enrollment processes, and fragmented care requiring patients to navigate multiple systems. Individual barriers include HIV-related stigma and internalized stigma leading to avoidance of care, mental health conditions including depression, anxiety, and trauma, substance use disorders, competing priorities such as employment, childcare, or caregiving, denial or difficulty accepting the diagnosis, lack of social support, medical mistrust, often rooted in historical discrimination, and health literacy challenges. Addressing these barriers requires comprehensive, patient-centered approaches combining individual support with systemic change. The federal Ending the HIV Epidemic initiative aims to reduce new HIV infections by 75% by 2025 and 90% by 2030. 7 Florida counties, including Broward, Duval, Hillsborough, Miami-Dade, Orange, Palm Beach, and Pinellas, are priority jurisdictions. The initiative is organized around 4 pillars. Diagnose all people with HIV as early as possible. Treat rapidly and effectively to achieve viral suppression. Prevent new transmissions using PrEP and other proven interventions, and respond quickly to potential outbreaks. Healthcare professionals contribute by routinely offering HIV testing, providing rapid linkage to care, prescribing PrEP to at-risk patients, and ensuring patients achieve and maintain viral suppression. The Ryan White HIV/AIDS program is the largest federal program specifically for HIV care, providing a comprehensive system for people lacking sufficient coverage or resources. Ryan White serves over 600,000 clients annually with 91.4% achieving viral suppression. Part A provides emergency relief to disproportionately affected metropolitan areas. Part B provides grants to states including the AIDS Drug Assistance Program, which provides medications to eligible individuals. Part C funds outpatient ambulatory services. Part D supports services for women, infants, children, and youth. Part F includes AIDS education and training centers. Ryan White is the payer of last resort, filling gaps for uninsured and underinsured patients. Patients facing financial barriers should be referred to local Ryan White programs. Now let's move on to the psychosocial considerations that are integral to comprehensive HIV care. HIV-related stigma remains a pervasive barrier to testing, prevention, and treatment. Stigma manifests at multiple levels: structural stigma embedded in laws and institutional practices, interpersonal stigma involving discrimination, rejection, or negative attitudes, and internalized stigma when individuals accept negative beliefs about themselves. Research consistently demonstrates that HIV-related stigma is associated with adverse health outcomes. Stigma discourages testing, delays care entry, reduces retention and adherence, and negatively affects mental health and quality of life. Stigma particularly affects communities already experiencing marginalization, compounding existing disparities. Healthcare settings are not immune from stigmatizing attitudes. Persons with HIV report discrimination, including refusal of services, excessive infection control precautions, confidentiality breaches, and insensitive comments. Such experiences erode trust and discourage future healthcare engagement. Strategies to address stigma include education, including U=U messaging, contact with people living with HIV, policy advocacy, and creating welcoming clinical environments. Healthcare professionals must examine their own attitudes and practices. Mental health conditions are substantially more prevalent among people living with HIV, including depression, anxiety, PTSD, and substance use disorders. These conditions may predate diagnosis, develop in response to diagnosis, or reflect shared risk factors. Mental health conditions negatively impact HIV care outcomes. Depression is consistently associated with reduced adherence, delayed linkage, and poor retention. Integrated care models co-locating mental health services with HIV care improve access and outcomes. Screening for depression, anxiety, trauma, and substance use should be routine, with appropriate referral and treatment. Substance use intersects with HIV through direct transmission via injection drug use, effects on decision-making, increasing risk behaviors, and challenges to treatment adherence and retention. Injection drug use is a direct transmission route, and non-injection substances also increase risk through behavioral effects. Active substance use should not be a barrier to HIV treatment. Current guidelines recommend ART regardless of substance use. Medication-assisted treatment for opioid use disorder reduces injection drug use and associated HIV risk and can be integrated with HIV care. Healthcare providers should offer or refer for medication-assisted treatment and provide non-judgmental care. Support systems play a vital role in helping people living with HIV navigate their diagnosis and maintain engagement in care. Support may come from family members, friends, romantic partners, faith communities, peer support programs, and professional counselors. Peer support programs, in which people living with HIV provide support to others with HIV, have demonstrated effectiveness in improving retention in care, adherence, and psychosocial outcomes. Florida offers numerous community resources for people living with HIV, including AIDS service organizations that provide case management, support groups, and direct services. Peer navigation programs that pair newly diagnosed individuals with trained peers. Housing assistance programs. Food banks and nutrition services. Legal services for issues including employment, discrimination, and housing, and community health centers with HIV expertise. Healthcare providers should be familiar with local resources and provide referrals as appropriate. The Florida HIV/AIDS hotline at 1-800-352-AIDS connects patients with local services throughout the state and operates in both English and Spanish. Quality of life has become an increasingly important focus in HIV care as life expectancy has increased. Health-related quality of life among people living with HIV is affected by physical symptoms, medication side effects, comorbidities, mental health, social support, and socioeconomic factors. Providers should assess and address quality of life as part of comprehensive HIV care. Here's a clinical pearl on addressing stigma in clinical practice. Use non-judgmental language and ask about sexual behavior and drug use for all patients without assumptions. Normalize HIV testing as routine healthcare, not judgment of behavior. Share the U=U message, as this directly counters stigmatizing beliefs about transmission. Protect confidentiality rigorously and display visible LGBTQ+ welcome signs. Now let's discuss the legal, ethical, and regulatory considerations that govern your practice in Florida. Several Florida statutes govern HIV testing, reporting, confidentiality, and related matters that healthcare professionals must understand. Florida Statute Section 456.033 establishes the HIV/AIDS continuing education requirement that this course fulfills, recognizing that healthcare professionals must possess current knowledge to provide safe care. Florida Statute Section 381.004, known as the Omnibus AIDS Act, addresses testing requirements, informed consent, confidentiality of test results, and exceptions. Florida Statute Chapter 384 governs sexually transmissible diseases, including mandatory reporting under Section 384.25 and partner notification services under Section 384.26. Florida law provides enhanced super confidentiality protections for HIV test results exceeding standard medical information protections. HIV test results may only be disclosed to specifically authorized persons: the patient or legal guardian, healthcare providers directly involved in care, authorized Department of Health employees for surveillance, health facilities when necessary for treatment, insurers under specific circumstances, and others as authorized by law. HIV status should not routinely be shared with healthcare workers not directly involved in care. Written authorization is generally required before disclosing HIV information to unauthorized persons or entities. Authorization must specifically mention HIV. A general medical records release does not authorize HIV disclosure. Healthcare professionals who improperly disclose HIV information may face professional discipline, civil liability, and criminal penalties. Florida law requires informed consent before HIV testing in most circumstances. Required elements include informing the patient that an HIV test will be performed, explaining the test and its purpose, and providing opportunity to ask questions and decline. Consent may be oral and documented. Written consent forms are not required. Exceptions to consent requirements include significant exposure incidents for testing source individuals when healthcare workers are exposed, court-ordered testing, prenatal care unless the patient affirmatively declines, and medical emergencies when testing is necessary for diagnosis and the physician documents this basis. Post-test counseling is required for positive results, including explanation, disease information, and referral to care. Florida addresses partner notification through voluntary public health services rather than mandatory provider disclosure. Provider responsibilities include counseling newly diagnosed patients about notification importance, informing patients about health department services, reporting diagnoses as required, and respecting confidentiality while encouraging disclosure. Disease intervention specialists can confidentially notify partners without revealing the index patient's identity. The Americans with Disabilities Act prohibits discrimination against persons with HIV in healthcare, employment, and public accommodations. Healthcare facilities must provide services regardless of HIV status. Refusal violates the ADA. Healthcare professionals have an ethical and legal duty to treat patients with HIV. Standard precautions effectively prevent transmission in healthcare settings. To summarize the Florida statutes, Section 456.033 establishes HIV/AIDS continuing education requirements, requiring providers to complete approved education for licensure. Section 381.004 addresses testing and confidentiality, requiring informed consent, superconfidentiality, and post-test counseling. Section 384.25 requires disease reporting, specifically reporting HIV diagnoses to the county health department. And Section 384.26 addresses partner notification, requiring providers to counsel about notification and refer to Department of Health Services. Now let's discuss special populations and health equity, because understanding the unique needs of different populations is essential for providing effective, equitable care. Men who have sex with men continue to be the population most affected by HIV, accounting for approximately 67% of new diagnoses. Among men who have sex with men, young Black and Hispanic Latino men are disproportionately affected, reflecting intersecting marginalization. Healthcare considerations include routine HIV testing at least annually, with more frequent testing every 3 to 6 months for those with multiple partners. Active discussion of PrEP, comprehensive STI screening at anatomic sites of exposure, hepatitis A, B, and HPV vaccination, and culturally responsive affirming care. Barriers include homophobia, confidentiality concerns, and lack of providers comfortable discussing same-sex sexual health. Providers can address barriers by creating welcoming environments, using inclusive language, and displaying visible LGBTQ+ acceptance. Transgender individuals, particularly transgender women, experience disproportionately high HIV burden. Approximately 14% of transgender women are living with HIV, with prevalence exceeding 40% among Black transgender women. Research demonstrates viral suppression rates are lower among transgender women compared to cisgender individuals. Healthcare considerations include awareness of elevated HIV risk, integration of HIV care with gender-affirming healthcare when possible, attention to drug interactions between ART and hormone therapy, though most interactions are minimal, and use of chosen names and pronouns. Barriers include pervasive discrimination, economic marginalization, housing instability, and prioritization of gender-affirming care over other health needs. Racial and ethnic disparities in HIV are among the most pronounced health inequities. Black and African Americans represent 38% of new diagnoses despite 12% of the population. Hispanic and Latino individuals represent 27%. These disparities are not explained by individual behaviors, but by structural factors including poverty, segregation, incarceration, and limited healthcare access. Addressing disparities requires attention to social determinants of health. Research documents that Black Americans are less likely to be prescribed PrEP despite higher incidence, less likely to achieve viral suppression, and experience higher HIV-related mortality. Culturally responsive care includes acknowledging historical medical mistreatment, building trust, employing diverse staff, and partnering with community organizations. Women represent approximately 19% of new HIV diagnoses, primarily through heterosexual transmission. Women face unique biological vulnerabilities and challenges accessing services. Healthcare considerations include routine testing, PrEP discussion with awareness that injectable CABLA is effective for women, reproductive healthcare including cervical cancer screening, contraception counseling, and intimate partner violence screening. With comprehensive interventions, perinatal transmission is below 1%. Youth and adolescents represent approximately 21% of new HIV diagnoses, yet have the lowest viral suppression rates of any age group, reflecting developmental considerations, transitions in care, and barriers to accessing services. Confidentiality concerns are paramount for adolescents, who may avoid testing or treatment if they believe parents will be notified. Healthcare providers should understand Florida laws regarding minors' consent to HIV testing and treatment and should clearly communicate confidentiality protections to young patients. Developmentally appropriate education is essential. Adolescents benefit from information presented in relatable formats and from providers who communicate without judgment. Supporting the transition from pediatric to adult care is critical, as this period is associated with high rates of disengagement and loss to follow-up. Transition planning should begin early, with gradual assumption of self-management responsibilities and warm handoffs to adult providers. Adults over age 50 now represent approximately half of all people living with HIV in the United States, reflecting both the aging of populations diagnosed in earlier decades and new diagnoses among older adults. This population faces unique challenges including polypharmacy and increased risk of drug-drug interactions, accelerated age-related comorbidities including cardiovascular disease, diabetes, bone loss, and neurocognitive impairment, social isolation and loss of support networks, and ageism in both healthcare settings and the broader community. Healthcare considerations for aging adults include comprehensive medication review to identify interactions and simplify regimens when possible, proactive screening and management of comorbidities, attention to bone health, cardiovascular risk, and cognitive function, and assessment of social support and mental health. Older adults newly diagnosed with HIV may face additional challenges, including lack of familiarity with HIV, limited social networks of others living with HIV, an intersection of HIV stigma with ageism. Persons who inject drugs require integrated HIV and substance use treatment, access to syringe services programs, and medication-assisted treatment. Active substance use should not be a barrier to HIV treatment. Rural populations face geographic barriers to specialized HIV care, provider shortages, and often greater community stigma that may discourage testing and disclosure. Telehealth has emerged as an important tool for extending HIV care to rural areas. Immigrants and refugees may face language barriers, cultural factors affecting health-seeking behavior, fear related to immigration status, and trauma histories that affect trust in healthcare systems. Culturally competent care includes using inclusive language for all patients, examining implicit biases, employing diverse staff, providing interpreter services, partnering with trusted community organizations, and addressing structural barriers, including transportation and childcare. Disparities reflect social determinants and structural factors, not individual failings. Here's a clinical pearl on culturally competent HIV care. Use inclusive language and ask all patients about sexual behavior and substance use without assumptions. Display visible welcome signs for LGBTQ+ patients and people living with HIV. Employ staff reflecting communities served and provide interpreter services when needed. Address structural barriers, transportation, childcare, and flexible appointment times. Now let's look at emerging topics and future directions in HIV care. While ART can durably suppress HIV replication, it does not eliminate the virus, which persists in latent reservoirs within long-lived cells. Consequently, treatment interruption results in viral rebound, necessitating lifelong therapy. HIV Cure Research aims to develop interventions eliminating the need for continuous treatment. Two cure concepts are distinguished: a sterilizing cure that completely eliminates all infected cells, and a functional cure, also called sustained remission, in which some infected cells remain but immune control prevents viral rebound without ART. At least 10 individuals have achieved remission following allogeneic hematopoietic stem cell transplantation for hematologic malignancies, most from donors with the CCR5 delta 32 mutation. These cases provide proof of concept but are not scalable. Research continues on shock and kill strategies, gene therapy, broadly neutralizing antibodies, and therapeutic vaccines. Despite decades of effort, an effective HIV vaccine remains elusive due to viral diversity, rapid mutation, and immune evasion. A 2025 study published in Science demonstrated that mRNA-based vaccines could successfully initiate maturation of broadly neutralizing antibody precursors in humans, representing significant proof of concept. While a licensed vaccine remains years away, this germline targeting approach represents the most promising current pathway. Long-acting formulations represent a significant advance in both HIV prevention and treatment, offering alternatives to daily pill taking that may improve adherence and acceptability for some individuals. For prevention, long-acting injectable cabotegravir administered every 2 months demonstrated superior efficacy to daily oral PrEP in clinical trials, making it an attractive option for individuals who struggle with daily adherence or prefer injectable administration. For treatment, the combination of long-acting injectable cabotegravir plus rilpivirine allows virally suppressed patients to replace daily pills with monthly or every 2-month injections. Additional long-acting formulations are in development, including lenacapavir, a capsid inhibitor administered every 6 months that is currently approved for treatment-experienced patients and is being studied for PrEP. These innovations may transform HIV prevention and care by removing daily pill taking as a barrier to effective HIV management. Innovations in HIV service delivery aim to improve access, efficiency, and outcomes. Telehealth has emerged as an important modality, particularly for stable patients and those in rural areas. Research demonstrates telehealth can maintain or improve retention and viral suppression while reducing access barriers. Other innovations include same-day ART initiation programs that have improved linkage to care and time to viral suppression, pharmacy-based HIV services including testing and PrEP dispensing, home-based and self-testing options that expand access and reduce stigma, mobile health applications for adherence support and appointment reminders, and artificial intelligence applications for epidemic modeling, outbreak detection, and prevention resource targeting. The COVID-19 pandemic accelerated adoption of many of these innovations, demonstrating the resilience and adaptability of HIV service delivery systems. Healthcare providers should stay informed about emerging service delivery models and consider how innovations might improve care for their patients and reach individuals who face barriers to traditional clinic-based services. As we conclude this comprehensive course, let me summarize the key concepts we've covered. We examined the epidemiology of HIV at global, national, and Florida levels with emphasis on disparities and populations most affected. We explored the pathophysiology of HIV infection, including viral structure and replication, immune destruction mechanisms, and disease progression. We discussed comprehensive prevention strategies including PrEP, PEP, U=U, and treatment as prevention, and harm reduction. We reviewed HIV testing types, diagnostic algorithms, window periods, and Florida consent requirements. We covered antiretroviral therapy principles, recommended first-line regimens, laboratory monitoring, drug resistance, and management of special populations. We examined the HIV care continuum, barriers to engagement, and Florida-specific resources. We addressed psychosocial aspects including stigma, mental health, and substance use. We reviewed legal and ethical responsibilities under Florida law, including testing consent, super confidentiality, reporting requirements, and partner notification. And we discussed special considerations for priority populations experiencing disparities. Healthcare professionals are essential partners in addressing the HIV epidemic. Every healthcare encounter is an opportunity to advance prevention, diagnosis, and treatment goals. Through routine HIV testing, you can normalize testing and enable early diagnosis when treatment is most effective. Through active discussion of PrEP with patients at risk, you can prevent new infections. Through rapid linkage to care and same-day ART initiation for newly diagnosed patients, you can improve outcomes and prevent transmission. Through ongoing support for adherence and retention, you help patients achieve and maintain viral suppression. By complying with Florida HIV laws, you protect patient rights. By providing compassionate, stigma-free care to all patients regardless of HIV status or risk factors, you demonstrate that healthcare is a welcoming place for everyone. And by staying current with evolving HIV science and guidelines, you ensure you are delivering the best possible care. Through these collective actions, healthcare professionals can contribute meaningfully to the shared goal of ending the HIV epidemic in the United States and Florida, reducing new infections to near zero, improving health outcomes and quality of life for people living with HIV, and addressing the health inequities that have allowed the epidemic to persist and disproportionately affect certain communities. The scientific and medical tools to end HIV are available and proven effective. What is needed is the will, commitment, and sustained effort to deploy them universally and equitably. Thank you for completing this comprehensive HIV and AIDS continuing education course. We will now review the exam questions to solidify your understanding. This review will cover each question, identify the correct answer, and explain the rationale behind it. Let's begin. Question 1. According to the course, what percentage of new HIV diagnoses in the United States occur in the southern region? The correct answer is 51%. Rationale: the southern United States represents a disproportionate burden of the HIV epidemic. While the region accounts for approximately 38% of the national population, it bears 51% of all new HIV diagnoses. This geographic disparity is driven by a combination of socioeconomic factors, including higher rates of poverty, reduced access to healthcare services, persistent stigma surrounding HIV, and in some areas, policy environments that create barriers to prevention and treatment services. Understanding this regional concentration is essential for Florida healthcare professionals, as the state is a significant contributor to these southern statistics and is designated as a priority jurisdiction for federal HIV intervention efforts. Question 2. At what CD4 count level is a patient classified as having AIDS, also known as stage 3? The correct answer is below 200 cells per microliter. Rationale. The CD4 T lymphocyte count serves as the primary marker of immune system function in persons living with HIV. The Centers for Disease Control and Prevention staging system classifies HIV infection into 3 stages based on CD4 count. Stage 1 indicates a CD4 count of 500 cells per microliter or greater. Stage 2 indicates a count between 200 and 499 cells per microliter. Stage 3, which is the clinical definition of AIDS, occurs when the CD4 count falls below 200 cells per microliter, or when certain opportunistic infections are present regardless of CD4 count. At this level of severe immunodeficiency, the patient becomes highly susceptible to opportunistic infections, such as pneumocystis jirovecii pneumonia, which is why prophylaxis with trimethoprim sulfamethoxazole is initiated when counts drop below this threshold. Question 3. Post-exposure prophylaxis, or PEP, must be initiated within what time frame after potential HIV exposure to be effective? The correct answer is 72 hours. Rationale. Post-exposure prophylaxis is an urgent medical intervention that involves taking antiretroviral medications after a potential exposure to HIV in order to prevent infection. For PEP to be effective, it must be initiated as soon as possible following exposure, with the absolute maximum window being 72 hours. However, earlier initiation correlates with greater effectiveness, and ideally treatment should begin within 24 hours of exposure. Once started, the PEP regimen must be continued for a full 28 days. Healthcare professionals should counsel patients that PEP is not 100% effective and is intended as an emergency measure rather than a substitute for consistent use of prevention strategies such as pre-exposure prophylaxis or condom use. Question 4. Which HIV test type has the shortest window period and is used to detect acute HIV infection? The correct answer is the nucleic acid test, also known as the HIV RNA test. Rationale: different HIV testing methods detect different biological markers and therefore have varying window periods, which is the time between infection and when a test can reliably detect it. Nucleic acid tests directly detect HIV genetic material, specifically viral RNA, in the bloodstream. This allows them to identify infection during what is called the eclipse period, which occurs before the immune system has produced detectable antigens or antibodies. The window period for nucleic acid tests is approximately 10 to 33 days, making it the shortest of all available testing methods. By comparison, fourth-generation antigen and antibody combination tests have a window period of approximately 18 to 45 days, while antibody-only tests may take up to 90 days. Nucleic acid tests are particularly valuable for diagnosing acute HIV infection when patients may be highly infectious but would test negative on antibody-based assays. Question 5. Which class of antiretroviral drugs is recommended as the preferred third drug in most first-line HIV treatment regimens? The correct answer is integrase strand transfer inhibitors, commonly abbreviated as INSTI. Rationale: modern antiretroviral therapy typically consists of a backbone of 2 nucleoside reverse transcriptase inhibitors combined with a third active agent from another drug class. Current clinical guidelines from the Department of Health and Human Services recommend integrase strand transfer inhibitors as the preferred third drug for most treatment-naive patients. This recommendation is based on several advantages of INSTI, including their high potency in suppressing viral replication, their high barrier to resistance development, their favorable tolerability profile with fewer side effects, and their minimal drug-drug interactions compared to older drug classes such as protease inhibitors and non-nucleoside reverse transcriptase inhibitors. The INSTI currently available include bictegravir, dolutegravir, and cabotegravir. These agents have become the cornerstone of modern HIV treatment regimens. Question 6. The federal Ending the HIV Epidemic initiative aims to reduce new HIV infections in the United States by 90% by what year? The correct answer is 2030. Rationale: the ending. The HIV Epidemic in the United States initiative is a federal public health campaign launched to leverage advances in HIV prevention, diagnosis, and treatment to dramatically reduce new infections. The initiative has established ambitious but achievable targets based on the widespread implementation of proven strategies, including early diagnosis, rapid treatment initiation, pre-exposure prophylaxis, and comprehensive harm reduction services. The specific goals are a 75% reduction in new HIV infections by 2025 and a 90% reduction by 2030. The initiative focuses resources on the geographic areas most heavily affected by HIV, including 7 priority counties in Florida. Healthcare professionals in these jurisdictions play a critical role in achieving these targets through routine testing, prompt linkage to care, and consistent messaging about prevention options. Question 7. Under Florida's Omnibus AIDS Act, what is required before performing an HIV test? The correct answer is informed consent, which may be oral and documented. Rationale: Florida Statute Section 456.033, known as the Omnibus AIDS Act, establishes specific requirements for HIV testing within the state. The law mandates that informed consent be obtained before conducting an HIV test in most circumstances. Importantly, the statute does not require written consent. Instead, consent may be provided orally by the patient, with documentation in the medical record that consent was obtained. The required elements of informed consent include informing the patient that an HIV test will be performed, providing an explanation of the test and its purpose, and offering the patient an opportunity to ask questions and to decline testing. This approach balances patient autonomy and protection with the public health goal of increasing routine HIV testing. Healthcare professionals should be familiar with these requirements, as well as the limited exceptions that permit testing without consent, such as in cases of occupational exposure or when testing is court-ordered. This concludes our review of the exam questions. Remember that understanding both the correct answers and the underlying rationale will help you apply this knowledge in your clinical practice as a Florida healthcare professional. Question 8. According to the U equals U, or undetectable equals untransmittable principle, a person living with HIV who maintains viral suppression below what level does not transmit HIV sexually? The correct answer is D, 200 copies per milliliter. Rationale: undetectable equals untransmittable, commonly abbreviated as U equals U, represents one of the most significant advances in HIV prevention messaging. This principle states that people living with HIV who achieve and maintain an undetectable viral load, defined as below 200 copies per milliliter for at least 6 months, effectively have no risk of transmitting HIV to their sexual partners. This finding is supported by robust clinical evidence, most notably the partner studies, which followed thousands of serodifferent couples, meaning couples where one partner is HIV positive and the other is HIV negative. These studies documented zero linked HIV transmissions when the HIV positive partner maintained viral suppression. This message is powerful for reducing stigma and encouraging treatment adherence, as it demonstrates that effective treatment is also effective prevention. Question 9. What is the largest federal program specifically designed for HIV care that serves as the payer of last resort for uninsured and underinsured patients? The correct answer is A, the Ryan White HIV/AIDS program. Rationale: the Ryan White HIV/AIDS program, named after a young hemophiliac who became a national spokesperson for HIV awareness after contracting the virus through a blood transfusion, is the largest federal program dedicated specifically to HIV care in the United States. The program provides a comprehensive system of care for people living with HIV who lack sufficient health coverage or financial resources to pay for care. Serving over 600,000 clients annually, the program functions as the payer of last resort, meaning it covers services not paid for by other sources such as Medicaid, Medicare, or private insurance. The program's effectiveness is demonstrated by its outcomes, with 91.4% of clients achieving viral suppression. The AIDS Drug Assistance Program, while important, is actually a component within the broader Ryan White program rather than a separate entity. Question 10. Which type of sexual exposure carries the highest per act risk of HIV transmission? The correct answer is D, receptive anal intercourse. Rationale: understanding the relative risk of different exposure types is essential for patient counseling and risk reduction strategies. Receptive anal intercourse carries the highest per act risk of HIV transmission among sexual exposures, estimated at approximately 138 transmissions per 10,000 exposures, or 1.38% per act. This elevated risk is attributable to the anatomical and physiological characteristics of rectal tissue. The rectal mucosa is a single cell layer that is more fragile and more easily traumatized than vaginal tissue, which has multiple protective cell layers. Additionally, the rectum contains a high density of CD4 positive target cells that HIV preferentially infects. By comparison, receptive vaginal intercourse carries a risk of approximately 8 per 10,000 exposures, while insertive vaginal and insertive anal intercourse carry lower risks still. This information should inform targeted prevention messaging and risk assessment conversations with patients. This concludes our review of the exam questions. Remember that understanding both the correct answers and the underlying rationale will help you apply this knowledge in your clinical practice as a Florida healthcare professional.